Hello, good morning, Ian. Is Jean-Claude Laborde? We can see you. Can you hear us?
Jean-Claude Laborde, we can see you. Can you hear us?
We can hear you loud and clear, Jean-Claude.
Well, I'm here and we are going to spend 1 hour with you. We have a prestigious panel here. You will see them one by one. I'm sorry, there is a huge echo, so I hope it's not disturbing you too much.
It's not too bad, actually. We can't see your panel, though, Jean-Claude, but we know that you're there with Alan Young and a very big panel. Could I introduce my team to you here at Monash? And I first want to congratulate them all for coming in on Saturday to do this case. It's a fantastic team and I'm just so delighted to work with everybody in this room. I'm joined by Rob Gooley, who's my primary assistant, and Liam McCormack, who's our fellow who's training with us. There's Liam. And of course the incomparable Cara Zantuck, who is our scrub nurse there. Siobhan Lockwood, who's off screen, is our non-invasive imaging expert and does the transesophageal echoes for our program. She's been doing those since we started in the year 2008. Deb Devonshire is our anaesthetist over my shoulder here, and there are a host of other people in the room here that I want to thank for coming in to join us for this case.
Great, Ian. Fallon. Good afternoon.
So,
Good afternoon.
hi Alan, how are you? Nice to talk to you as usual.
Yes. So maybe you can tell us about the case and then we get going. I know that you also have to give a lecture as well after, right?
Absolutely. So I'll ask Rob to tell us about the case. So if you could bring up the slides, we'll tell you a little bit about the case.
Thanks, Ian. So today we're performing a transcatheter aortic valve implant on an 82-year-old female. She's 163 centimetres tall, 72 kilograms, so rather robust, and with a BMI of 27 kilograms per metre squared. She presented with exertional breathlessness, currently NYHA class 3, along with some exertional angina, but interestingly has also had 2 episodes of syncope in the last few months. Comorbidities are that of paroxysmal atrial fibrillation. She's normally on rivaroxaban for that, and that has been withheld for the last 48 hours prior to today's procedure. She has had a previous history of ischemic heart disease and has had a PCI to the mid-LAD 2 years ago now. Otherwise, she's got type 2 diabetes, hypertension and some dyslipidemia. As far as her risk prediction, of course, she's had an STS risk score which is 5.9 and a Euro score of 3.5. As we often find, these are relatively modest numbers, but probably undercall her level of frailty. So we do a number of frailty indices. Namely, we've done her 5-metre gait speed, which we can see is a little prolonged here at 8.2 seconds for the 5 metres, and a low hand grip strength of 7.4 kilograms in the dominant hand. So she's been through our normal TAVI workup process and has been discussed at our heart team meetings, where the feeling was it should be best served with a transcatheter valve given her advanced age and that frailty leading to a high operative risk. I might just hand over to Siobhan, who might be able to actually show us some live echo images rather than the table.
Thanks, Rob. So hopefully you can see my transesophageal echo images here, and you can see on 2D imaging that she has images consistent with severe aortic stenosis. Her transthoracic echo confirms severe aortic stenosis with a V max of 4.5 metres per second across the aortic valve, a mean gradient of 47 millimetres of mercury, and an estimated valve area of 0.8 centimetres squared using the continuity equation. She has only trivial other valvular disease, including trivial aortic regurgitation, mitral regurgitation, and tricuspid regurgitation. Her ejection fraction, you can see here, is normal, and not surprisingly, she has a small left ventricular cavity with increased wall thickness consistent with a woman with severe aortic stenosis. Unfortunately, though, she has a normal estimated pulmonary artery pressure. If we just look at her valve in short axis quickly, I think it's important to realise how calcified this valve is and how relatively immobile that non-coronary leaflet is, and you can see that here. I'm using the pointer. A very heavy leaflet calcification involving the non-coronary leaflet. and limited but still adequate valve leaflet motion of both the left and the right. So that's important to keep in mind when we're choosing the correct device and for the proceduralist to use as a marker for implantation. Thanks, Rob.
And if we could go back to the slides, I think Ian's just going to go through the CT data set.
Thanks, Rob. So, Alan, Jean-Claude, as is the standard everywhere around the world now, multi-slice CT helps us with our sizing, and it's particularly important with this valve because it's not an oversized prosthesis. We have a 320 slice CT embedded in cardiology, and all of these images are acquired and assessed by the interventional team themselves. This is just showing you the basal plane measurements using the 3Mencio software, and you can see the maximum and minimum diameters there, 26.1, 18.7, with an average of 22.4. Our perimeter, probably our most important measurement, 69.7, and there is a perimeter-derived diameter, assuming a circular structure, which of course it's not, is 22.2, and an area-derived diameter of 21.4. And the area at the moment is 360. So that'll circularise up to somewhere around 380 to 400 square millimetres. This is the left ventricular outflow tract. You can see the LV outflow tract is a little smaller, average diameter 22.7. The perimeter 68.5, perimeter derived diameter 21.8. The area there around 328 square millimetres, and the area derived diameter of 20.5. So certainly in the range of a small prosthesis for the Lotus valve so far. The measurements are also made through the sinus of Valsalva at the height of the coronaries, and you can see here the images on the right and the measurements on the left. You can see we've got adequate cusp widths. We have an average area of just under 700 square millimetres. Now we're using a 23 millimetre Lotus prosthesis today. The rule of thumb is 600 to 800 square millimetres, so we've got a right in the middle of that range for sinus area. And you can see the coronary heights are all pretty adequate, 21, 18 for the 15.6 and 16 millimetres for the left and right coronaries. Just next slide, please. This is the peripheral anatomy, and you can see full reconstruction, 3D volume rendered reconstruction there from the CT. You can see the vessels do get a little bit small on the left side, but certainly big enough for the 23 millimetre 18 French sheath. We elected to go on the right side. I should say they're a little bit smaller on the right side. We elected to go for the right side just for convenience, but we could have used either side for access here. One more. Coronary angiograms done, show mild coronary artery disease, certainly nothing critical, probably the most significant disease a little bit in the middle of the circumflex, minor proximal, come back please, and you can see the aortogram there, tricuspid valve, reasonable angle. Next one. And of course, many of you are now familiar with the Lotus valve. It's different from the other two prostheses that are widely used. It is not balloon expandable. It's not entirely self-expandable. It's a controlled manual mechanical expansion of the valve. It's maintained on 3 coupling fingers even when it's fully deployed, and you release it at your leisure when you're happy with the final position. It's braided nitinol valve frame. Bovine pericardial leaflets of standard thickness. It has a central radio-opaque marker, which you can see there, which becomes very important for the positioning of the valve. And it has this wonderful adaptive seal on the outside of the valve frame, which is essentially like cling wrap, which fills up those little fractured interstices around the valve, and it seems to be, thus far, very successful in minimising the burden of paravalvular aortic regurgitation. Next slide. Of course, it has a ergonomically designed and very nice handle. It's a simple anti-clockwise rotation to unsheathe, shorten and expand the valve. And of course, at any time if you want to reposition, it's just simply wind the handle the other way. The one-to-one relationship is extremely good. The valve, of course, is pre-mounted on the delivery system, which is certainly very efficient and just needs to be drawn back into the handle. Next slide. And this slide should be updated because there is now 3 prostheses at 23, 25 and 27. We're just showing you here the 2 prostheses that we had until a couple of weeks ago, 23 and 27, but there is now a 25mm prosthesis. And you can see the recommendations for basal plane and sinus areas there for the 23 and the 27. And from the numbers that I've told you, you now know that we're in the range of the 23mm prosthesis and should have a nice fit with that valve. And you can see the compressed adaptive seal when the valve's shortened and fully expanded. Next slide. So this is our procedural plan, and perhaps we should take questions and then we can move on. We're doing this procedure because of it's a live case under general anaesthesia with transesophageal echo guidance. That's TEE for North Americans. We've taken a left femoral 6 French access, and we have the Lotus introducer sheath, the 18 French sheath, in the right femoral artery. Of course, we did the standard pre-close technique using 2 pro glides. And at the end of the procedure, we'll do a crossover balloon collusion technique, which we do routinely. We have femoral venous pacing from the left femoral artery, and we're using just a small balloon, a 18mm nucleus balloon. But of course, we've done a couple of cases even with peripheral balloons as well, certainly not going aggressively with balloon dilatation today. And our standard approach is to use the short axis of the LVOT as being the measure for the largest balloon diameter. So it's a 23mm Lotus valve. We estimate the perimeter oversizing is only going to be about 3%. So we should have fairly good apposition and hopefully good reduction in paravalvular leak. Questions?
Ian, it's just an impressive, nice presentation that you give us, I think, all the information for any discussion. I'm not sure there will be a lot of discussion because so far it's extremely clear and about the patient selection, the anatomy, the choice of the 23, the strategy. I don't know if anybody wants to add something, but I guess that is extremely clear. And so if there is no question, I would say that we will be delighted to see you performing the cases as it is set up by this slide and this wonderful presentation. Ian.
Thank you very much, Jean-Claude. If I could then take it as read that you're happy. We've already put the wire in the ventricle. So if I could just show the aortogram. If we could bring up, that's an aortogram we did at the start of the case. You can see we found a nice orthogonal view with the 3 cusps on view with the pigtail catheter in the non-coronary cusp. And you can see conveniently we have some nice calcification on the medial aspect of the non-coronary cusp on the leading edge there. Siobhan pointed that out to you on echo. And that will help us with our positioning of the Lotus prosthesis, which of course positions from the middle and expands from the middle and shortens from both ends. So if you could go to the last image, please. Our last angiographic image. We're just storing all the fluoro here, and you'll see the wire is not absolutely perfect position, but as Siobhan said to you before, we have a fairly crowded small ventricle, and if you look at the transesophageal echo images, you can see the outline of the wire. If we can just bring up the toe for a second, you can see the transesophageal. You can see the wire. It's almost back to the mitral valve. We had considerable difficulty getting it further into this little crowded heart. So we're just going to keep a very close eye on that because of the, as you know, the nose cone extension. So we'll go ahead with the balloon valvuloplasty now.
Ian,
so if we can go live, we're just...
Maybe one question,
we'll
Ian, if you have time. The question will be, which is the wire that you are using? I was wondering if Boston is not giving a pre-shaped wire. I'm not sure is listening. Ian, did you hear the question?
Safari wire they're questioning.
Yes, there is the pre-shaped Safari wire. We don't have access to that routinely here at the moment, and we found that just shaping the Boston super stiff wire usually gives us a very nice shape. Unfortunately, this heart is a little bit small and a little bit crowded, so I did want to demonstrate actually that you could get it in a very nice position. So we'll just test the pacing if we could. Yep. So bring up hemodynamics and we'll just show the pacing test.
Pacing off, please.
Pacing off, that's great. Okay, good. All right, so again, our plan is never to be too aggressive with the, so there's the balloon across, so pacing on, please. You ready?
Pacing's
Go.
on,
Go.
balloon going up.
Balloon
coming
pacing
down.
off, okay. So I think like yourself, Jean-Claude, we've increasingly moved towards just gentle balloon dilatation to open it up, and in some cases no balloon dilatation at all. Just keep the wire forward if you can.
Sorry,
Good.
Ian, what
That's
size
great.
is this balloon?
And we certainly have not... this was just an 18mm balloon.
Right.
Okay. It's sized but against the short axis of the LV outflow tract. We don't want to overexpand a small eccentric and calcified LV outflow tract. So, but recently we have actually done quite a few cases, well, we've moved towards doing peripheral balloons, just to make an 8-10mm lumen and let the valve do the rest. So if we could just pan now onto change cameras, and we'll just show you if we could come down on our hands here. All right, and this is the delivery system, the delivery catheter, and you can see that it is pre-shaped and it is curved. And so you have to negotiate this curve into the body, and this does help you when you get to the arch, and it certainly helps you to have coaxial alignment with the valve plane, but it does require a little bit of negotiation in tortuous anatomy. So if we could just resheathe that ever so, the nose cone's a little bit too far out. Just need, just resheathe. That's good, that's great. And we'll just load this on.
So that's why you need a super stiff wire to really straighten out that curve when you go up. Later on, you'll be able to get across the arch.
Yeah. Yeah. So Alan, actually even the super stiff wire does not straighten this out.
Enough.
So it does require a little negotiation. You'll be pleased to know that the version that's coming in as part of the US trial, not probably at the very start, is a much more flexible and much more forgiving, absolutely beautiful new catheter. This design is great, but it does require some understanding of the shape of the catheter, and you can see in order to get it in, we have it in a, just take that across a little bit further, that's good.
Where is the wire?
Yep. You got the wire? Yep, good. And just ease a little bit of wire back, if you could. Just ease a bit of wire back first. Okay, so we're just making sure that there's not too much wire in. And if we could go down to the periphery and just ease it back a little bit, it's too much tension on. Okay, and just go to a straight AP. Okay, and I'll bring the valve into the sheath. And we'll just stop for a second and I'll show you some of the features. Just straighten the system out a little bit for me. Okay, and I'll just record that for a second. If we could play that. You can see the nose cone very clearly. If we could bring the static image up, the nose cone very clearly. You can see the end of the braid there. You can see the posts just inside the braid, they're the base. You can see the radio-opaque tantalum marker in the middle of the valve, and more proximally down in the bottom left-hand corner are the collars and buckles, and there are mandrels running between those which will lock these things together like a seat belt. So now the most important thing now is we just keep our eye on this. Just go back to a 17 centimetre field, and we tend to follow the nose cone of the valve and the radio-opaque marker. And the radio-opaque marker helps us tell about the orientation. And you can see that it's rotating around. Now let's go up and have a look at the wire in that little ventricle for a minute. And so take a bit of tension out of the wires, too much tension there. That's good, that's great, that's great. Back to the valve if you could. And we will now just take the valve gently up the descending aorta. Keep the radio-opaque marker on view if you could please. Ease the wire back a little, just a little bit of wire out. little bit further. Now, the ideal crossing position, if I can just record this for a second, I won't worry about the pigtail at the moment. We'll fix the pigtail in a second. If you could come onto the replay image there. Now, you can see the tantalum marker is now very clearly in the left side of the chest or on the right side of the screen. And that tells us that the catheter is actually going to be turning towards the arch because that tantalum marker is on the outside of the curvature, and so that tells us that the catheter will naturally curve over the arch if we have it as a fairly stand-up straight soldier to the left side like that. Okay, so if we could just go round to an LAO for please, if we could. That'll do, that's far enough. And if we just, now just a little bit of tension on the wire, and then what we'll do is we'll travel over the arch very gently and slowly. And don't worry about our pigtail, we'll fix him up in a minute. Just keep the tip of the catheter on view, please. That's great. And you can see if you have that marker in the right position, it will just naturally turn over pretty nicely. So we'll stop there for a second, and we'll just reposition the pigtail. Now, Alan, when you start in the US, and with Jean-Claude coming to teach you, you'll have a beautiful new, more flexible delivery system. But this system works fine, you just have to the marker. So if we could go to a 15 centimetre field. All right. Okay, so now all we do at this stage is just simply take the valve. We already know that our landing zone, we want to get, I'll just record that for a second. No contrast, please. I'll just record this. Now, the aim here is we want that tantalum marker to be somewhere adjacent to the upper edge of that calcified nodule on the non-coronary cusp, which is going to be roughly adjacent to the top of the pigtail. And that will mean we will be about 5-6 millimetres up the leaflet. Go back to the live fluoro image, please. Live fluoro, thanks. So, and just a little bit of wire out, take a little bit of wire out of the ventricle. Right, the pigtail in a nice position. And we're just crossing now, and all we're going to do is just cross through the valve plane, and Rob will just very nicely start to extrude the valve. So off you go, Rob. I'll just go through a little bit further to get the base of the braid through. Off you go. So if you can see Rob's hands now, you'll be able to see he's just gently anti-clockwise rotating. Now for core valve users, you'll see that the valve looks like it goes in a little deeper, but remember it's going to shorten from both ends. So I'm just going to go hold it across very gently, just slowly, Rob. That's great. Just ease a little bit of wire out, just a tiny bit. That's good. Okay. And we just keep that across. Just pull back a bit. There you go. Okay. Slowly, 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 slowly. And just stop there. Now we're going to transition, and you can see the tantalum marker now is above our ideal landing zone, the top of the pigtail. So I'll just do a quick aortogram there, and we'll just show you where we are. We've got good pressure, so we're all right. Okay, so can I toe probe back for a sec?
I think you have the probe echo just in front. Oh, thank you.
So our tantalum marker is a... Righto, that's okay. So now all I'm going to do now is just allow that tantalum marker to land in the right position as we expand the valve. Just slowly, Rob. And if it gets too far and it drops in too deeply, all I do is ask Rob to just rewind and resheath it. So pressure's still up and looking good, and you can see the tantalum marker now dropping into position. You'll go slowly. I'm just going to hold that in position for a minute. Hold that. It's dropping a little, so we'll just see how that looks. Keep going. Keep going. Valve's expanding nicely. We've still got good pressure. The period of hemodynamic stress is very minimal, so I'm just going to hold that here and expand a little bit more. That looks pretty good. Stop, stop, stop. Now what I'm going to do is lay it over a little bit into the flow plane, because we've got a little bit of a waste on the valve. So just have a quick look at that, Siobhan. Tell us, are we deep, shallow?
So Ian, when you say land over, that means that you advance a little the catheter to make a better axillization of your valve to the anatomy. Is it correct?
to make a better actualization of your valve to the anatomy. Is it correct?
Sorry?
I was saying, when you
Yes,
say
I
land
advanced
over,
the
that's
catheter.
mean
I
you
called it
advance
laying it over a little, and I'll just have a see. I've just just laying it so I get nice coaxial alignment, Jean-Claude. So because you've got a waist, you know that it's not going to push into the ventricle. So what do you think, Siobhan? Middle of the valve so far?
Middle of the valve looks okay.
Okay. So what we'll do now is we'll do an aortogram. Now, it's important to know that that's all been done without any hemodynamic stress, no pacing required, no drama. So now we'll have a little look and see what it's looking like. Okay, so that's not a bad position. And what we'll do is we may just lay it over a little further. I'll just lay it over to get it a little bit more coaxial. We can have the toe probe back for a second. Right, and if you continue to expand. Now Rob is actually expanding, and now you can see clearly the buckles coming down towards the post. Stop there. Now at this position, I'll just screen that for you. You can see the nose cone is fairly a fair way out into the ventricle. So just shorten the wide just ever so slightly. And now what we're going to do is make sure that the buckles and posts are aligned so that we don't cross-thread them. So it's collar, buckle, post, and we're just going to have a quick look around and see how well aligned they are. That looks pretty good.
Yeah, it looks
Okay,
great.
pressure normal, still in sinus rhythm. Okay.
Great.
Sorry?
There is a huge echo, I'm sorry.
There we go. Buckles and posts look pretty well aligned there.
Oh, I'm sorry.
And we'll go back to the... Right. So now what we might do at this point is we might just do another aortogram and see about the depth of the valve. And Siobhan could interrogate this because the valve is pretty much close to functioning but still a distance to lock it. So I'll do the aortogram first if you like. Right. Okay, so, and of course if we're unhappy with the position we can reposition it, probably in at about 4 millimetres on the non-coronary side. What do you think so far actually,
So far,
Jean-Claude?
so far it looks perfect. Maybe what you say that was great in to maybe realign a little more again your valve, because it's still a kind of a tilt, but this is, I'll let you to decide.
Still kind of a tilt, but
Yeah.
this is I'll let you to decide.
Yeah, I think we do need to lay it over a little more, but what we'll do is I think we'll accumulate a bit more layover as we go to lock the valve. There's still a small amount of paravalvular leak, so it may be possible for us to reposition just ever so slightly a little higher. We'll just see what Siobhan thinks.
Yeah, I agree. With respect to the landing zone, we use the markers of the hinge point of the anterior mitral leaflet, and we're probably a touch ventricular with respect to that. We also use the base of the septum as our 2 ventricular markers. So we can see here, if I put colour on, you still have a degree of paravalvular regurg rising adjacent to the anterior mitral leaflet, and I think we're just a touch too ventricular.
Okay, so we've got a good position. Just show the hemodynamics for a second. So there's the hemodynamics. So the valve's not locked. So we've got the option now of making a minor adjustment to the height of the valve to get more of the adaptive seal over the leaflet insertion point. So we think that's what we ought to do. So what we're going to do, just go back, there we go. So if you can have toe probe back for a second. So Rob's going to re-sheath the valve ever so slightly now, and I'm just going to allow it to ride up. And if you keep your eye on the radio-opaque marker in relation to the pigtail, you'll see that as he re-sheaths, the radio-opaque marker will climb up the pigtail. There it is starting to move now. There we go. And we might just let it come back a little higher. And then I'll hold it in a higher position until the valve grabs. So, there we go. Stop there, stop there. Now that's good. So we've just repositioned it a little bit more proximally. So now if you hold that, Rob, I'll hold that. Off you go, just slowly. So we're just going to have the valve slightly higher position. Keep going. And to start with, I'm just going to pull back a little until the valve grabs. There you go. It's a bit higher. That's nice. Just hold there. Just go slowly. So that's good. Now, not applying much tension at all. Keep going slowly. Slowly. And you can see a waist is forming on the valve now, so that means it's expanding nicely. Stop there. Now I'll just lay it over a little bit. Now the valve is higher by about 2 or 3 millimetres. So what we might do is let's just zoom up, have a look at the... and you can see how we moved that radiopaque marker in relation to the pigtail, just simply by resheathing a little bit and holding it in a slightly different position. We're looking at the alignment of buckles and posts here. Yep, they look pretty good. And go back to the landing zone. So Siobhan, if you just interrogate that, and then we'll get a quick aortogram, and I'll just lay it over a little bit more there. Okay, so that's definitely higher, isn't it?
Yeah.
Can everybody see that the valve is now higher in relation to the aortomitral curtain?
Yes, and one question is, do you think the valve will continue to shorten at that stage?
One question is, do you think the valve will continue to shorten at that stage?
Yeah, it will, but I think we'll end up at a pretty good position, though. I think it will, but you know, at this position at lead-in, you can pull to pull the bottom up, you can just hold it neutral and allow the valve to close from the top and the bottom, or you can apply slight forward pressure just so that there's slight domination from above down to the valve. And that, of course, you don't want to do too much of that. But you've got a couple of different options of how you can actually close the valve at this position. So let's get an aortogram. What do you think about the paravalvular leak?
We are still seeing some. It's probably related to that heavily calcified non-coronary leaflet that we
Right.
saw earlier.
Righto.
So it's to be expected, but I think the valve is in an otherwise good position.
Okay, and you can see the nose cones moving and flexing freely on the curved wire. You can bring the topo back just a little. Okay. So have you got any comments, Alan, at all? Just going to lay it over a little. I'm just laying the valve over it. That's actually pushing it forward ever so slightly to make it more coaxial. Let's get an aortogram. Right. Okay, so there's a tiny bit of paravalvular leak, not much, but it's still there. So let's just go on towards closing the valve now. So we just zoom up.
So
And we'll
Ian,
just
it
go
looks
on
like
close.
it is
So we're
about
going to lock
4 or
the
5
valve
millimeters
now.
below the
Now what we want to do
non-coronary
is just
cusp.
get the...
It is about 4 or 5 millimeters below the non-coronary cusp.
I wouldn't say 4 or
maybe a little
5.
less.
You can see the non-coronary cusp there. I'd say it's probably
3.
3 at most.
How about
it's
the other
19
side?
millimetres final, so to
Yeah.
our mid-tantalum marker there is only going to be
So just have a
roughly
look.
9.5.
We're still in a good position there. Because just look at the base of it. I don't think we wouldn't be 5.
How about the other side, Ian? On the left, right corner?
No, I don't think
The
so.
other side, Ian.
Yeah.
Yeah, left, right corner.
Oh yes. So now is that an adequate depth? Just open up the. Come back with the toe probe for a second. Just want to make sure we are below the non-coronary cusp there by going for a higher position. Just ease the wire back ever so slightly. Right, and just open the plane between the two. No, this way, that's right. And we can see now the buckles and posts are locked. I'm just concerned about the depth, whether we, as Jean-Claude mentioned before, by repositioning more proximally, you can see as the valve is shortened, just got to make sure we remain below the non-coronary cusp. But of course, we can unlock the valve and drop it in a little more deeply if we need to. So, could I have an aortogram, please? That's probably cutting it a bit fine, don't you think?
Does look a little higher
Yeah,
on the
just
non-coronary side
just
there.
look at fraction high on the non-coronary. Just let's open out a bit, and we'll just drop it just down ever so slightly. And I'll just apply a little bit of. There we go. Hold it there, and I'll just. There you go. You go. Just lock that for me. Holding it still. Yeah.
They're locked there.
Yeah, we're locked again there, and the valve's nicely locked. Now let's have a look at that position. We'll just have a look to interrogate that by toe. So we just took it a little deeper. We just, probably a millimetre or two. So we're just interrogating that on toe. And you can see the prosthesis very stable position. You know, you don't need to hold on to it. It's locked in a fairly good position. There's a modest waist on the valve. So it looks like a pretty good position. Can everybody see that valve position now? It's just below the leaflet insertion point. Doesn't look like there's much paravalvular leak now. We've got the adaptive seal in a nice place. The valve's locked. So let's just go around and look to see that the valve is locked in a number of different places. Toe probe back for a second. You can see how calm and relaxed the procedure is because we've got the opportunity to make very minor adjustments to the valve plane if we're not happy. And so we're just looking to make sure that it's locked. Okay. Yeah, and so buckles and posts are nicely opposed. You think so, Rob?
Yep, I think we're locked on all three posts.
Just pull a little bit of tension off the wire. Back to our view. And I think, okay, we can go ahead and trip the force limiter. Okay. I'll just go a little bit off axis just to open those two up. Now you'll see a little gap appear between the buckles and posts as Rob continues.
We're just going to anti-clock that delivery handle right to the end of travel.
And that little click there was we've tripped the force limiter.
And take that handle as far as we possibly can.
So the valve is now locked and the force limiter is tripped, but we still don't have to release it. So here we are at 100% of our final position with the valve in place. We could go home for lunch if we actually wanted to. I'm not holding on to it. You know, don't need to hold on to it. And so what we will do now is I'm just going to move the pigtail back, and we usually leave it there because it helps us with the marking. We'll set it on the top, somewhere there like that. Just take a wee bit of tension out of the wire. That's great. And we'll have a little look with an aortogram and see what's going on here. You ready? Just... Okay, so that looks like a pretty good position. What do you think, actually, Jean-Claude or Alan?
I don't see any PVL now, so I think it's fine. The small angulation of your valve will change with the final release, so I'm very, very positive so far. And plus, the ostia of the coronary looks to be higher than the frame, so it's great.
The coronary looks to be higher than the frame, so it's great.
Yes, yeah, so that looks good. So, so what we're going to do now is if we go with the lights up, Rob will demonstrate for you the release collar mechanism. So we're focusing on, if we could zoom in on this part of the handle here. All right, and okay.
So now that we're at the end of travel with the primary delivery knob, we will open the release collar. That exposes the release knob. And there's two stages to the release process here, which is fairly important given that even during this first stage of release, we can actually fully retrieve this valve. So I'm actually not going to be watching what happens on the screen because I'm watching two little markers on the handle here.
So if we could have that image on Rob's hand as a perfect. And for those of you who are watching carefully, you can see just next to the nose cone extension, there's a little black dot, and that black dot is the pin, the head of the pin cable. And Rob's going to pull up the pins now. You ready? Go.
Yep. So I'm going to clockwise rotate until
there's the pins are up.
Pause symbol that lines up with the line on the handle, meaning that we can still fully retrieve at this stage.
Can we have the replay image up, please? Okay, the replay image. Now and if you watch that through, you'll see the pins coming up. There they are, boom, up come the pins. And so the mandrel is no longer locked into the post. That's the tuning fork-like structure at the bottom. However, we haven't disabled the valve. We could still retrieve it now if we needed to. We haven't disconnected. So if we want to, we'll have one quick final aortogram. Just 10 mils will do, just to show the valve position. Okay. You ready?
No. One sec.
Yep. Ready to go. Ready to go. Okay, this valve's in pretty good position. There's no paravalvular leak. So we're happy to release the valve. So this is the great advantage of this, is we made some adjustments. We got it in a position that we actually liked. You happy with the position, Siobhan?
I'm happy.
Okay, Siobhan's happy, so we're happy. and so now Rob is going to go and uncouple. So you'll watch this live.
So this is the second stage of the release mechanism. We're going to go beyond that pause point, so we now cannot retrieve the valve.
And you can see the coupling fingers will come off now. And just as Jean-Claude predicted, the valve tipped over a little bit to be a little bit even more coaxial with the flow plane when we did that. And so now the next stage is just retrieving the handle. So the valve is off now.
So we've gone to the end of travel with this release knob. We go back to the delivery knob and we resheath that nose cone, which will bring all of those coupling fingers back into the catheter and bring the nose cone back towards the end of the catheter.
We're not going to leave the wire across. There we go, lift off. That's our little lunar module lifting off. And we don't bother leaving the wire across. We can come back across if we wanted to assess AR. What we normally do is capture it and then we'll take it over into the descending aorta. And now we'll just align the nose cone very nicely. Okay, off you go, Rob. And he's going to just recapture the nose cone and just make sure we can, that's good. And just slowly, just gently get the nose cone to come into the...
Just got to be careful here not to oversheath that nose cone. So we leave that little gap you can see there on the...
So in order to get it out of the sheath. And then the trick is just simply to take it out the way you came in. There you can see the curve in the catheter. And we've just got to just make sure that we emulate that curve as we're coming out. And if you just see how we follow the curve. And it's important not to rip it out, but actually to follow the curve and take the curve out in accordance with the shape of the catheter. If you just let that go for a second, you can see I've pulled it a little bit out of shape now, but you can see the shape on the end of the catheter there. There's still a lot of curvature on it. Okay. So let's go quickly back and have a look at our valve. Get a final aortogram. Now, of course, we could cross and do an AR index, but I'm not sure that we need to do an AR index if we don't have AR. So let's get an aortogram there. So you can see the valve looks very nice, and it is indeed coaxial with the flow plane, so we're pretty happy with that. So can we have the lights down to the usual level? And let's do 20 mils now. Always have the pigtail sitting on the top of the valve frame to do this, because it's good, and we have a standard approach to how much contrast, 20 mils at 20 mils per second, so they're all comparable. Okay, and there is a wisp of paravalvular leak there. Certainly not a great deal, but you can see just a little paravalvular leak. So probably because of that calcification, but certainly not extensive. And there's a little bit of central AR. So would you like to tell us what you think, Siobhan?
Thanks, Ian. So here we are in our mid-esophageal long axis view, and you can see the valve is sitting beautifully right within the Lotus landing zone.
Let's get ready.
So again, just our landmarks, if you like, is our anterior mitral leaflet, the hinge point where the valve moves from. So we're sitting right on that point, so that's fantastic. There's no obstruction to LV. The mitral valve leaflet mobility, so there's no LV inflow gradient, and we're sitting nicely on the base of the septum. You can still see that we can check with colour. We don't have any evidence of paravalvular leak. There is trivial valvular level regurgitation, but often we find that settles down shortly after all the wires have been removed. We can have a look in the short axis as well. And again, you can just get that hint of trivial valvular regurgitation, but there's nothing major with respect to paravalvular. Now, because of where the valve sits, sometimes we miss paravalvular regurg arising from the septal side, so we do often have to go into the transgastric view to get a better look on that side.
Just while you're moving into, are you going to the transgastric? Yeah. Can we just show the hemodynamics? I just want everybody to see. We've had a starting diastolic pressure of 44, and our diastolic now is 43, and you can see we're in sinus rhythm at a rate of 53 beats a minute. And we just get ready for the crossover technique.
So Ian, a question
you're
is
going
that
transgastric?
since these valves are of a fixed size, what do you tolerate in terms of oversizing or undersizing that this would be applicable?
So really, Alan, very good question. You can't undersize it all because you can't thus far we don't believe you can post-dilate the valve because it has a locking mechanism that relies on the valve expanding to a certain size. So we basically don't undersize. And in terms of oversizing, if you oversize too much, it's like putting a seatbelt on a very overweight person. You can't get the buckle and post to lock together. So it is very much a right-size valve. So at the moment we only, for much of the first couple of studies, we only had two valve sizes, so we had to reject people that are either less or more. That's great. You can see, can we see live there the wire going down for our crossover technique? Now our standard procedure is actually lock the wire outside the body so that we're in the sheath, and we just simply do that so that we've got both antegrade and retrograde access if we need it. So I've locked the wire outside the body in the sheath. So Rob's just going to now, I'll just pull this over and we're just going to put a flexible sheath in, and we tend to do a crossover balloon technique. So there we go, I'll take that out, I'm holding that down. Any questions? So yeah, so importantly it's a right size valve, Alan, it's not an oversized valve.
So maybe one question, Ian. It looks like the strategy you used today.
The guys,
One question, Ian. It looks like the strategy you used today.
You didn't use at all oversizing, and then you implant your valve as you wanted, quite high in the LVOT. So can you give us a view of the risk of pacemaker with this strategy? Is it a new strategy? Because we all have seen that for the Lotus valve, the pacemaker rate was a little high, I would say, compared to the Edwards, of course, and even a little higher than core valve. So do you think there is a room for improvement there?
Yeah.
Do you think there is a room for improvement there?
Yeah, I think there is. There absolutely is. I think my personal view about the pacemaker rate with the Lotus was the limitation of only having two valve sizes and perhaps overstretching patients in the top end of the 23 range and the top end of the 27 range. And I think while height of is appropriate, is important, I do believe that what we've got to get right is the sizing so that we don't overstretch. And I think the reason we didn't get a problem here today is that we've got an appropriate sized valve, so there's only a 3%. Now the guys are going to close this up and I'm going to depart to go around to get ready for the lecture, so I'll be round there in about 2 minutes. So if you excuse me, I'll see you again in a couple of minutes.
Whatever, congratulations again
Thank
for
you.
these brilliant cases, Jan.
Whatever, congratulations again for these brilliant cases. Yeah. Thank you.
Maybe a question, how many people when you do percutaneous closure, do you actually do crossover, do anything particular, or just sort of take it out and close and see what happens? Do most people still sort of do balloon occlusion, do various things? Any comments?
One thing I learned, Alan, that everybody does their own strategy and everybody is convinced of using the best one.
Yeah.
So I will not go too much in detail. I like what they are doing so far because finally it's an extreme secure attitude. Extreme secure attitude to have a balloon. We will not see it because I think Ian will come and make his presentation, but this finally having a balloon contralateral is allowing you to close the vessel without bleeding, and if you have a bad surprise, finally you are already ready to advance and reinflate your balloon in a position where you have bleeding, so your patient can virtually have no retrobal bleeding despite complications at the iliac level. So I think it's extremely safe. After that, I think some are using this technique only when there is a risk with the iliac, and some are never using it, so I cannot comment more. I am in favor of that.
What do you do? Do you just...
I use the balloon, not all the cases, but every time that is a little difficult to advance the 18 French, or is tortuous calcified, or the ProStar didn't work, the ProGlide didn't work optimally, I think it's safe to have the balloon rather than the pigtail.
Any comments?
I think that's our rationale here at Monash, that we prefer to have it there and just do it routinely rather than in an emergency be fumbling trying to get it across.
What is interesting, I guess I would like to have your feeling, because it was interesting to see that it's the first time, you know, finally in TAVI, that you implant a valve and you are not completely satisfied. The position was not bad, but it was not optimal. Finally, they changed to resheet the valve and to place it optimally. It is something new. We have to discuss that, because is it safe? I think so, but some may raise the issue of expanding many times in the anatomy, raising the risk of stroke, who knows, you know. Whatever, I think it's a very new strategy to be able to do that with TAVI. We didn't have that with Edwards or Corval so far.
Jean-Claude?
Yes.
Labo? It's me.
Oh, yes.
Yes,
please.
you are the expert in the Corval. And we in Korea, in this panel, we have two tools, the balloon expandable and self-expandable. Frankly speaking, do you need these additional new technologies needed in a real practice? So we have only two sides of the Lotus, 23 and 27, and the previous some baseline, the CT diameter, and then real coronary angiography, big differences size measure. So, what do you think about this?
Well, it's the question I've been a little answered by Eberhard before yesterday. Finally, stating something that whatever you say, you will be willing to test, to try, to see where is the interest of these devices, because we cannot just stay on the podium and saying, "Oh, it looks interesting." We will be keen to use it if it's attractive. The question is, and again, I think it will be the discussion probably during this session or this afternoon, it is that we stated with Corval and Edwards with devices that prove to have advantages and disadvantages. And some of those devices are taking care very nicely of some of our disadvantages, but they have their own disadvantages that they will have to show, and or we will have to reveal to be sure that the balance is positive for these new devices. So far, I think the only way to know is by testing them.
Great, Ian, we see you live, so I guess you'll be ready to give your talk, right?
Thank you, I am, and that's an absolutely perfect segue what Jean-Claude has just said. And I do agree that the only way to know whether these new technologies are any good is by testing them. The thing that I would draw to your attention is that we only have 3 Lotus valve sizes at the moment, but I think eventually there will be 5 or 6 so that we cover a full range of sizes. So if you can see my slides, I hope you can. I'm going to talk a little bit about second generation devices, strengths and weaknesses, and I want you to recognise that I do have a conflict in that I do receive consulting fees and honoraria from Boston Scientific and served as a proctor. Now, in this brief presentation, there are some caveats and conditions. I'm not going to give a parade of new valves. You've got a wonderful panel of experts who can talk to you on that. But I am going to, if you like, have a parade of clinical problems with novel approaches to finding their solutions. The talk is not comprehensive. I won't discuss all the specific new technologies, and I've given you a few examples there. And it's not a detailed analysis of stroke or pacemakers. I heard Gerald Yong's lovely presentation on strokes previously. And the other thing is it's not a data dredge, because I think most of you know that data, and I think that's pretty uninspiring.
Now, it goes without saying, we now have from these wonderful randomised controlled trials, the partner study and indeed the US core valve IDE study, there's a wonderful data set that shows superiority over medical therapy in patients with extreme risk and equivalence or possibly superiority to surgery in high-risk patients. And as a consequence of the clinical quality of life and economic data, we've seen transcatheter valves grow rapidly. 50,000 up to 2012, and between 2009 and 2012 probably quadrupled the number.
So Ian, we have the satellite time may cut off in 5 minutes.
I've got here some of the technology.
The satellite time may cut off in 5 minutes, so I just want to warn you just in case. So,
yeah, I can hear you.
Yeah.
Yeah. Okay, that's right. Okay, so we'll look, there the list of the possible technology gaps there, the access issues, positioning, repositioning, stroke, pacemaker, aortic regurgitation, all those things that were mentioned. And of course there's a whole lot of other issues that we need sorted out as well, vascular access, support wires, better valvuloplasty balloons, etc. Now, this slide was lent to me, of course, by Eberhard very kindly, and we can see that there are a number of second-generation technologies attempting to address many of these problems. And probably the ones that we best know are shown on this slide, and I'll go through a little bit about these, particularly related to 4 issues. And I really only want to talk about access issues, device positioning, repositioning, paravalvular regurgitation, and valve hemodynamics. To access issues, we all know that femoral first is probably the best strategy, but sometimes the femoral arteries are too small, too tortuous, too calcified, or all of the above. And so we've looked at alternative access routes. But instead of looking at alternative access routes, we could have smarter sheaths, we could have full redesign of the existing technologies, or we could have out-of-the-box technologies. And in a sense, we're seeing second generation and beyond approaching access issues these ways. Smarter sheaths, full redesign of existing technologies, and indeed out-of-the-box technologies. And we've seen the new Evolut Enveo delivery system. It's an inline sheath. This is very ingenious. So the sheath is already behind the valve, so you don't have to have a sheath bigger than the valve. It's the same size. And this, of course, is capable of being delivered into relatively small vessels. This is one of our cases, and you can see here is a patient with pretty small peripheral vessels. This is a 12 French sheath, and you can see we were able to put the Evolut R easily through this vessel, even though it's not much bigger than a 12 French sheath. So the future looks pretty good. And of course, Sapien have a similar approach with their Commander sheath. And I'm sure you'll hear today about some new technologies, the Foldax valve, to reduce the crossing profile. The leaflets are now ahead of the valve frame. And I think this is an ingenious way of approaching and getting smaller and smaller technologies. So things are in sequential order rather than going in contemporaneously, all under the one stent frame. And this, of course, is the Foldax Folder valve delivery system where the valve heads in before the frame. Another example of these out-of-the-box thinking is the valve medical device, and this is a completely modular valve where you put the valve frame in first, then you bring the leaflets in, and then you lock the valve down. And in the interest of time, I won't go through all of this. The valve is ingeniously folded inside the sheath so that you can get right down to very small sizes. And you can see, I'll show you here a little video to show how it works. 12 French compatible. It's in the sheath. It goes in as a modular delivery system. What actually happens is you first go up into the descending aorta, you deploy a Hofnagel valve to allow you to have some control of paravalvular aortic regurgitation. You'll see that being operated here, and then through that Hofnagel valve you can then go on to the aortoventricular interface, and once you're in that position you're able to deploy the valve frame first, And once the valve frame is in position, you can see the valve frame being deployed, and the valve frame has this wonderful adaptive seal, which I'll say a little bit about later. And then the valve mechanism spirals out of the catheter, and you lock it down onto the valve frame using guide wires. Now, that means that you're able to deliver the valve in phases so that the crossing profile of the total catheter is only 12 French or 3.8 millimetres. Now, if these sort of technologies work, it's possible to imagine how this could be delivered from a brachial artery in the future. So that's access issues. I just want to say a little about repositioning, because I think this is really important. There's a lot of misconceptions about repositioning. People say you don't need it. That is not true. I've just demonstrated to you how useful a little bit of repositioning can be. That repositioning causes strokes? Well, there's no evidence for that. And that repositioning and retrieval are the same thing? That is not true either. Just to show you, these are the major clinical trials looking at disabling strokes by VARC 1 or VARC 2 with Rankin scores greater than 2, they're admittedly at 30 days, usually assessed at 90 days. But here in these trials, looking at the rate of disabling strokes, where there's been neurological assessment before and after, you can see that repositioning has not increased the rate of major disabling strokes when looked at objectively. Now, repositioning, we can see all of the technologies are looking at fine repositioning. As you know, the S3 system has this wonderful ability to make fine adjustments in the ventricular aortic dimensions, and we've seen that the Evolut R has this same capability as well, with this wonderful new designed handle and the ability to resheathe the valve inside this nitinol reinforced capsule allows you to reposition the valve very well. And again, in the interest of time, I won't show how the Evolut R valve actually works. It's a wonderful, wonderful iteration of the core valve, and we've been delighted to be part of this clinical trial. I'll just move forward onto the next slide if I can get it. And this is just showing you an Evolut R valve and how easy it is to position very well. This is just showing you the basal plane there. And you can see we've able to deliver the Evolut R very, very well because of its repositioning capabilities. Portico similarly has the ability to reposition, so it's obvious that everybody is moving in this way. And here is a nice example from Steve Worthley. You can see here, valve is too high. It's a simple case of resheathing the valve, repositioning it and starting again. So I think repositioning has real value to the future. Lotus I've just demonstrated to you, and here is a nice example with the Lotus valve. This is just my last slide possibly. You can see the valve is a little too deep there. There's paravalvular leak. You can see the patient has a complete heart block, but with minor repositioning, the valve's in the perfect position, no paravalvular leak, and complete heart block gone. So these things tell me that repositioning is indeed an important option. I don't believe it's a party trick. I think it's actually very, very important. And as we saw in the Reprise 2 study recently, the ability to reposition is meaningful. No valve migration, no valve embolization, no TAVI and TAVI. Finally, paravalvular regurgitation. This is what it looks like when you look at all of the studies, and you can see that from a number of studies that this has a significant influence on outcome. And I think I'm almost done for time. Yeah.
Thank you very much, Eden. It's a great look in the future, and I certainly, congratulations for a great case, and we learned quite a bit, and I'm looking forward to having maybe you to come and teach us how to do that in the States.
I'll look forward to it, and thank you very much for having us be part of the meeting, and Jean-Claude and the team, thank you.
Oh, thanks a lot, Ian, for this wonderful presentation.
Thanks, Alan.
Okay, thank you very much.